Okay, folks, so we have today Professor Karen Rodham, who's currently at Staffordshire University and has been there in that role for about 6-7 months. Yeah. Prior to that, Karen worked at Bath for quite a long time, actually, even though she's still relatively very young, and was one of the very early health psychologists who actually was working in clinical practice alongside academia. So there was a time when you could literally name on 3 fingers. You don't need a full hand to name the number of health psychologists who were working in clinical practice back when Karen was a trailblazer in that respect. So prior to that, Karen had worked for a little while at Oxford.
Yes.
You've forgotten that. And so is going to inform us all today about complex regional pain syndrome. Thank you, Karen.
Thank you, Mark. Well, thanks for inviting me. It's quite exciting to come back and find 2 faces that I didn't expect to be here, so it's brilliant. So yes, I'm going to talk to you about complex regional pain syndrome. Thanks for saying I'm young. Love you forever. A bit more about my background, just to fill in. Mark's covered the first point. I'm a chartered health psychologist, and for about 7 years I practised 1 day a week at the Royal National Hospital for Rheumatic Diseases, otherwise known as the Mineral, down in Bath. And I set up and ran the adult service for complex regional pain syndrome there. And it's thanks to David Blake and Candy McCabe that I did that. I wrote to them saying I was an academic health psychologist looking for patients to do research with. They were practitioners who had lots of patients and not a lot of time to do research, so if we wanted to collaborate, I'd really be interested in doing that. And David invited me along to sit in on his clinic. Was a consultant rheumatologist, he's now retired. And we were just talking to Mark about ethics, he didn't get any permission for me to sit in on his clinics or anything at all. And I knew then I would probably like him. And then he introduced me in different ways as, this is Karen, she's a scientist, do you mind if she sits in? And the patient said, oh no, that's fine. This is Karen, she's a researcher, do you mind if she sits in? This is Karen, she's my girlfriend, she's been shopping, do you mind if she just puts her legs up while I... And they all said, no, I don't mind. And I just thought, well, I am going to enjoy working with him if this is something that comes off. So I watched him in his clinic, and he had about 10-15 minutes max. The patients would come in, he'd have to talk to them, make them feel at home, whisk them into the other room, get their kit off, have a look at them, get them fully clothed again, and then record their letter while they were still in the room, and then send them packing, all within 10-15 minutes. And I was exhausted at the end of the day watching him, and he was charming and lovely, slightly naughty, but he had to focus on the symptoms. He didn't have time to really ask these guys how they were feeling. So when we were talking afterwards, I mentioned this as an observation. I said, you really need a health psychologist working with you. Not thinking of me, just thinking there was a gap there that needed to be filled. And he just basically said, come on then if you're hard enough. And I thought, okay, so I went back and talked to my then head of department and asked if he would then let me work 1 day a week. I wanted to stay employed full-time by the university because I wasn't sure about pension and money and salary and all of that. So they basically agreed to pimp me out for 1 day a week. So they sold me, the hospital paid for a day a week of my academic time, and then I started to work there. I started just by having patients come in, and I said to them I was a health psychologist, but I wasn't going to do any psychology. I just wanted to hear their story. So for about 3, 4, 5 months, I had the luxury of just hearing patients tell me their story. So I didn't know anything about complex regional pain syndrome. And some of you might not know about it, but you will at the end of today. So I had between 4 and 6 months of hearing their stories, and that enabled me to get an idea of common themes that were cropping up for them in terms of how they were coping or not coping. And that then enabled me to tailor a psychology service for them. And Candy and David were very supportive of that, and that service is still running. And it's being run at the moment by Claire Howard, who was one of the first MSCs that I taught when I was at Bath back in 2002. So she's all grown up, all qualified, and it's now running the service there down in Bath. So it's lovely. So it's thanks to David and Candy that I was one of these early people that was able to practice health psychology in the real world. So what I'm really interested in is on how people cope and how they cope with complex and chronic conditions, and more often how they don't cope and how we can help them cope better. So this is what I want to do with you today. Here's my outline. So I'll tell you a bit about what CRPS is here. I won't spend too long on what health psychology is, but I'll just flag it up because I've got a quote from Mark in there, so I need to put Mark's quote up. Tell you what coping is, talk about coping from my perspective, tell you a bit about how I've explored this issue, try and sum up what I think I've learned from this whole experience, and then finish on a whole bunch of questions that I think we still need to look at as health psychologists in this field. So that's my evil plan for this afternoon. So what's CRPS? It's a really, really painful condition. I mean, I know there's at least one person in the room that knows about it. Any of you come across this before? Complex regional pain syndrome? I'd never heard of it before I started working with David and Candy and had to do a lot of reading around and catching up. It's horribly painful, it can be really debilitating, and pain is the main overriding symptom that these guys have. Measuring pain is really tricky. We all know to measure pain is really tricky. If you're in pain and I ask you to tell me on a scale of 1 to 10 how much you hurt, I don't know what the answer is for me. I was asked that once when I hurt my arm, and I didn't know how to score my own pain. I just didn't know what, it was meaningless to me, and I couldn't think of a number. But this is what we ask patients to do, tell us your score, pain on a score of 1 to 10. And we've got lots of different scales and lots of different ways of measuring it. But pain is tricky, measuring pain is really tricky. It's quite dark, can you see these pictures all right there? So these are a whole range of different pictures that I found online that made me put faces like yours there. And to me that looks horrendous, but most of these guys are smiling, except this one. He doesn't look so happy. But they voluntarily, well, we hope, done this, and there they all are. I mean, this chap, who is he? You can't see his face clearly. I can see his face clearly. He's smiling and doing the thumbs up. So measuring pain is tricky. Other symptoms that they have hugely exaggerated reactions to normal stimuli. So I can hear that there's possibly an aircon on in this room, and some of you might be in a breeze from it. That breeze would be really painful for some of the guys that I work with. They're super sensitive to things like that. We have areas around us where we're comfortable. So getting a bit close now, if I didn't know you, I know both of you, but we get a bit uncomfortable. For a person with CRPS, going into a person's space, their personal space is bigger, and they start to feel pain if we get too close because they're kind of hypersensitive to everything. So it's really difficult for them. You can see that their limbs might swell. They don't swell all the time, they come up and go down, so it's unpredictable. They have temperature changes. The affected limb might be much hotter or much colder than the one that's not got CRPS. They have changes in hair growth. One lady I worked with called it the werewolf condition. So she had it in her arm, and she had thick black hair growing on the arm that was affected. The nails change. The way they grow change in the affected limb. It's a very strange condition. And they have altered body perception. So Jenny Lewis, who works down in Bath, did a really good PhD and continues to do really interesting work in body perception. And she got patients to draw how they saw their limbs. And this is how this person saw their arm. It was normal, and then it just kind of disappeared to this thing, and then there was a big mitten on the end. When we were looking at this person's arm, it was normal to our sight, but that's how they perceived their arm. So you've got all these weird perceptual stuff going on, which on top of that pain, incidentally, pain which medication doesn't seem to touch, at best takes the edge off, but doesn't really have any impact. So the guys that we work with down in Bath were often at the extreme end, and this is what I'm talking about, the ones that have chronic CRPS. And they would often come to us completely doped up on morphine. And so the first things that we used to do is bring down their morphine so that we can have sensible conversations with them and help them start thinking about other ways to cope. So pain is just horrendous, and it can peak, but it's always very, very hard. Cause is currently unknown, commonly arises after an injury, but the injury can be as simple as stubbing your toe or tripping over. So there's a very few patients that can't remember how it started and describe it as being spontaneous onset, but to my mind, if stubbing your toe can be a trigger, how often do you stub your toe or bash your hand in a day and don't even remember that way? So the cause is unknown, but it often happens after an injury. often after a break your arm or your leg, and it can start happening. Usually affects one limb, can affect more, can spread. In I think it's about 7% of cases. I'm looking at you, Helen, to correct me if I'm wrong. And up to about 80% of them, they describe them as kind of recovering. I wouldn't say get better, but up to 20% of them develop this chronic CRPS where it just is horrendous and really, really impacts on their world. And that's the 20% that I worked with, so that's what I'm most knowledgeable about. Just to give you an idea about how many people are affected, up to 20 to 90 people per 100,000 have CRPS. So I tried to find some other comparable figures for you, and I'm a qualitative person, so I'm not very clever with figures. But you can see it's kind of in the lung cancer MS range, and yet most of us don't know about it. So it's also difficult for patients when they develop this, because often GPs and health professionals haven't heard of the condition and don't know how to manage it. So diagnosis is difficult. There isn't a single diagnostic test. You have to exclude other conditions because the symptoms and the signs could be a signal that something else is going on. So you have to exclude that. Then you've got this tension, because if you can get in and start treating people quite quickly, there's a better prognosis. But most of the time when we were seeing guys, they spent months and months and sometimes years being bounced around the system trying to find out what was wrong with them. So it's very difficult for both the patient and the healthcare professional to try and find out what's going on and try and reach this diagnosis. So it's very, very difficult. What CRPS is not, lots of people have come to us, and as psychologists that's quite difficult. They've been told CRPS is all in their head. So you're then faced with someone who knows they've come into your office and that you're a psychologist. They can be full of quite a lot of anger that they haven't been believed, and they've basically been told it's all in their mind. The research tends to suggest it's not a psychological condition. There are some people that suggest it is. Lomberg and Altmaier reviewed the literature and conclude it's not fully supported. I think more work needs to be done there. But CRPS does have an impact on our psychological well-being. So to use their words, you don't get CRPS but you're nuts, but it can make you nuts. All right, this is what patients tell me. So what's it like to have CRPS? You're probably already starting to think, imagine if this was you or one of your loved ones, how difficult it would be to cope. You've got your diagnostic journey, meandering from health professional to health professional. Test after test is coming back telling you there's nothing wrong with you, but you know something's wrong with you. You're an expert, you know your body's not doing what it should be doing. There's a mistrust of the health profession, there's a mistrust of psychologists particularly. The mobility can be affected, particularly if it's in your lower limb, you struggle to get around more. You can get isolated because you withdraw, because it's difficult to go out and about. If your arm or your leg is super sensitive, going out on a busy street is going to be really difficult, and you start adopting avoidance behaviours. So your life becomes much smaller, so it's really difficult. That leads to relationship problems, it leads to identity problems, lots of fear, lots of avoidance, and lack of trust in your own perception. You're being told you're nuts, this is all in your mind, and yet you know stuff is happening. You also sometimes see strange things happening, so buildings might flicker, you might see movement where there isn't any. There's some perceptual thing that's interesting that's going on. Communication problems. If my partner really loved me, he'd just know how to help. There's that kind of assumption going on. So a lot of the work of the psychologist is helping them recognise that unless we can communicate clearly what's going on, psychologists aren't mind readers, so how can we expect our partners and carers to be a mind reader? You need to be able to express what's going on and to ask for the help you need rather than the help your carers are trying to give you. And again, the screen's quite dark, but on my screen this is beautifully clear. Becoming isolated, so that's someone too scared to come out of their front door. So here's a perceptual thing. Most people will look at that and definitely see there's a triangle. I looked at that and saw Pac-Man. There is no triangle there, but we see one. So there's perceptual stuff going on. If you move your head back and forward, they should make you feel a bit wobbly when you look at them. Are they moving for you, like the eyes in the snake from Jungle Book? Yeah. They're not moving, but they look like they are. And this one, there's grey dots at the intersections flashing about, but there isn't, but that's what we see. And this is the best I can come to trying to find out what they might be experiencing. So we know it's not there, and yet we're seeing it, and it's weird. So we start losing trust in our own perception about what's going on. What's it like to have CRPS? This is just a still from a YouTube video. And there's lots of unreliable stuff out there, but there's lots of good stuff out there as well in terms of what people have put up there. But the quote is, imagine being told all this is caused by something psychological because of a lack of understanding and comprehension. So your doctors, your health professionals are telling you this is all in your mind. What are you going to do? It's horrendous. So this is what it's like to have CRPS. It's a massive impact. It's horrendous. So I won't dwell too long on what is health psychology, because I'm imagining there's quite a lot of health psychologists in the room, but so won't be teaching you to suck eggs. But nevertheless, this is what we focus on as health psychologists. So we're really interested in the causes, prevention and treatment of physical disorders that are impacted on by psychological processes. So CRPS is perfect. It's a perfect vehicle for looking at how health psychology can help. There's your quote, Mark. I can't remember where it's from, but I've used it forever and ever. So this is what we as health psychologists are tasked with doing. Okay. What I like compared to other professions is that we look at the person in context. They're not just the leg in bed 2 or the person who's got depression in room 4 or whatever it is. They're the person living with something. So they're the person first and they're living with the condition. We're interested in their lifestyle, their environment, their relationships, the whole big puzzle that makes up them, rather than just the condition. And that's what I really enjoyed doing when I was in practice. I really enjoyed piecing together those different bits of the puzzle. I like this quote. It's about medical students. They're taught to take the history and examine the patient. It would be great if they took the patient and examined the history. And I think that's what we do really well as health psychologists. So we're looking at the bigger picture. We're exploring their history and looking how it might have contributed to where they are now. So how can health psychology help? What can we do? These are the treatment guidelines that Helen and I were just talking about. And Andreas Goebel and co have put them together, and they're kind of gold standard. This is what we do. Now, we can't cure CRPS. It's rehabilitative, and we're looking at improving function over and above everything else. They haven't found a cure yet. Lots of people are working on interesting and exciting research, but at the moment there's no cure. And that's a really hard thing to tell your patients, because they come to you expecting a cure. So my toolbox with patients, I went to Claire's Accessories, which is a horrendous experience, but I bought a pink shiny wand, and I broke that wand, and I used to have it in my desk drawer, and I used to show them there's no magic wand. And that they remembered that then, because they don't want to hear that message, but if you show them that message, then they remember it. Secretly they're hoping there's a cure, but if you can show them there's no magic wand, what we're going to do is help you focus on what you can do, make the most of your life, make it bigger, because invariably it's shrunk. And these guidelines are really helpful because they look at 4 different approaches to helping these guys. So we're looking at physical and vocational rehab. So we're involving physios and OTs. We're looking at psychological intervention. So they've actively acknowledged the role that psychologists have to play, which I think is really, really important. There's lots of pain management programs that are very medical focused. I think it's important to have the psychological perspective. There is a focus on pain relief. We look at medication, we look at the procedures, we look at if there is any medicine that might help them. And it's about patient information, giving them information, helping them, teaching them to understand their condition. Because if they're finding it difficult to understand, they're not going to be able to explain it to other people around them, and therefore they're not going to be able to get the help they need. So a lot of my job as a psychologist was to help them understand what CRPS was and help them find ways of explaining it to other people. So health psychology is just one part of the puzzle, but I think it's an important part. And of course I would, I'm a health psychologist. But we have a role to play in all 4 pillars. So in terms of pain relief, we can help educate and teach the patients about why it's important to stick to the medication routine they've been given. We can help teach them alternative coping strategies. There's a lot of work being done on mindfulness and acceptance and relaxation and distraction and all sorts of things like that can be helpful hand in hand with medication. If we don't teach them these skills, then they're stuck with just the medication, which doesn't work. In terms of physical rehab, a lot of them have very low self-esteem, they have a lack of confidence, they're very frightened. So part of my job often involved going down with a physiotherapist in the middle of a physiotherapy session and being alongside the patient and talking them through strategies to bring down their stress while they were in physio. So we can help them engage with the physio. Patient education, again I've talked about that, and psychological interventions. A lot of what we do is about behaviour change with these guys. So they've fallen into habits of doing things, and so we're trying to unpick those habits and create new ones to help them cope better. So coping, what is coping? I looked up coping in the Oxford English Dictionary. First two I understood. The third thing was a picture that came up on Google, and I have no idea what it is, but it's to do with coping. So if anyone can tell me later, that'd be brilliant, but I thought I ought to put it on. Do you know, Mark?
I've got a funny feeling it's something to do with like a coping sore.
I knew someone would know. Brilliant. Anyway, I just liked that came up.
It's following the line.
It's a beginner's magic trick. Sort of a woman in half book practice.
Yeah. First you see the hand and then you don't. So coping, and why do we need health psychology to understand coping? Well, we've got people with chronic illness. Of course CRPS chronic illness. Lots of different people have CRPS, lots of different people have different chronic conditions. They all cope differently with it, it impacts on them differently. Objective indicators don't explain why they're coping well or not well quite often. So they might score the same on a measure of pain, but they're not coping so well. So health psychology has the advantage of having different models that help us look at what's impacting on their coping. And I think that's where we can come in and make a big difference in pain management for people with CRPS. And one of the models I stumbled on, which is linked to cardiac events, is the life thread model. I think it's Ellis Hill and colleagues. And I just really like this model. It talks about threads, and we all have different threads of our life that we weave together to kind of tell the narrative of our life history. So you've got this lovely strong bit of red there that's somebody's life history. Then CRPS happens, and the threads are broken. And you're kind of all at sea. There's a few that are still joined up, but most of them have become frayed and are not connected anymore. So you've had the rug pulled around you. Now I'm mixing metaphors. So CRPS happens, your predictability of your life is lost, your identity is probably really severely impacted on, and you're just sort of in shock. If you're going to move on, you've got to find a way to reconnect some of those threads and perhaps leave some of them behind, and that's really difficult, really difficult. But your threads need to be managed. You need to create a new me and a new life narrative. And I think this model is lovely because its image is something that the patients in front of me can grasp and understand and get an inkling of what we're going to be doing with them when we're in practice. So the guys I see were really struggling to manage their broken life narrative. So my job was to help them mend that narrative, think about themselves in a different way perhaps, readdress their identity and look at what they could do instead of focusing on all the things that they couldn't do. Now that sounds really simple. I'm currently battling, and it's nothing compared to CRPS. My arm is almost not long enough now for me to see small type, and I am still resisting going and getting glasses. And there's no reason why not. I'm quite happy wearing glasses, but it's just a sign that I am not so young as you think. And I just need to man up, which is a phrase I'm told I'm not allowed to say anymore because it's not politically correct, and start rejoining my life threads and think, actually, it's fine. And when I'm in the hills walking, I can't read my map clearly, so I am going to have to get some glasses. And that's minor, but I'm struggling with that battle. So imagine what's happening if something as major as CRPS is happening. It's really difficult. So how have I explored this? From different perspectives. That's an attempt to show a different perspective for you. So I've looked at it from the perspective of the person with the condition, I've looked at it from their partner or carer's perspective, and I've looked at it from the health professional's perspective. That's on the Great Wall, so it was actually at that angle, in case you hadn't worked it out. So, perspective of the person with CRPS. Down in Bath, we had a 2-week inpatient programme. So we would get people who would come in, Candy and David would give the diagnosis, they'd assess them whether they were suitable to come in for our 2-week intensive rehab programme. Rehab was mostly physiotherapy, occupational therapy, hydrotherapy, and a bit of me on Mondays, because I was just there on Mondays. So I would see them on the Monday, give them homework, pick up again with them on the following Monday, and then do a couple of follow-ups afterwards. And I wanted to know what happened after the return home, because I was seeing them come in. When we first saw them for assessment, they were all at sea. Then they'd come in to our hospital, which is a darling little hospital. It's like you walk in and it's got a sweeping staircase. You can imagine people coming down in ball gowns in old bath times and all of this kind of stuff. And it's beautiful, and it doesn't feel like a hospital, and it's small, and everyone there understands CRPS because it's a national centre for CRPS, so the staff understand it. And then these guys are in on the programme with 4 or 5 other people with CRPS, so they're finally meeting someone else who has this condition, and they feel completely understood, they're supportive, they've got health professionals on tap. And then at the end of the 2 weeks they go home, and they go back to wherever it was in the UK, or sometimes further afield that they live, and there's no support. You know, to the best will in the world, we try and fix them up with ongoing support, but the NHS isn't set up for chronic conditions, so they would really struggle. So I wanted to see what happens after they've gone home, and follow them up and learn from that. And the themes that came out were all about a battle for control, and the programme was seen as a real turning point. Finally, it was an acknowledgement that they had something real. Their workmates, their family, their colleagues, other health professionals back home recognised it was real, because the hospital wouldn't take them in for a 2-week programme for something that was pretend. So they finally had validation that they had something real. So this was a real turning point for them. This was really positive. But then going home distanced them from the pool of expertise, and they felt all lost again. So we needed to think about how to manage that kind of transition back home. Another positive was it helped them realise it wasn't all in their head. There was still this doubt, and then being invited to come in on a 2-week programme helped them recognise and understand that it was real. So it helped them as well as their colleagues understand. And then the NAG list was something that was quite interesting, that at the end of their rehab, the physios would draw up a list of exercises and things that they wanted them to do. The OTs would do the same, and the psychologists would also do the same. So they'd be presented with this list of stuff to be getting on with before their 3-month follow-up. And this was really useful because they could present it to their partner or carer as a nag list, that these are the things I can give you permission to nag me about, but don't nag me about anything else. And so it helped them manage getting support from their partners as well. So there were lots of things that we learned from talking to these guys about how we could help them cope better when they went home. So we helped them create nag lists before they went home. So that was really important. And we also emphasised that they could call us up, they could phone us up if things went pear-shaped between now and the 3-month follow-up. They didn't have to wait. Not many of them did phone us up, but knowing that option was there helped calm down their nerves. What else have we done with patients? We've just finished an NIHR-funded thing, looking at support needs. This is my partner in crime. We've done lots of writing together, lots of travelling together. This is Leon Watts, he's computing. This is Neil Coulson, he's in Nottingham, and that's me. So I put the 2 long hairs on sort of a baldy sandwich, if you like. And they know that I say that, so it's okay. And what we wanted to do, the guys that I was working, we've done lots of work on internet forums, but lots of these internet forums have been set up and running for some time. And what we wanted to see was how support started from scratch. And the patients that I was working with were telling me there was an awful lot of information out there in the internet world. There wasn't much that really captured their voice. There was lots from the medical and the health profession, but nothing really saying it from their perspective. So they wanted to have a Wikipedia page that presented their perspective. So we got some funding to build a page with them, and to set up a discussion forum from scratch, so we could sort of look at how support developed from nobody being in a support forum to it growing. So we followed the forum over a few months. Then we launched the development of the wiki page. What was fun and also horrible was that we were hacked, which meant we got lots of fake members suddenly. We got really excited thinking that it had taken off, and then we realised we'd been hacked. So that caused all sorts of problems, but at the same time it made us very proud that we were important enough to have been considered worthy of being hacked. But so we had to call time on the forum because that was just too difficult with the hacking incident. But the wiki page we continued trying to develop. And what we found was that although in face-to-face conversation with us when we were developing the grant, they were really keen for this, when it came to it, they didn't want to put their thoughts publicly on this wiki page. It was a closed wiki page. It was just those members who had agreed to take part in our research, but they didn't want to put their thoughts in public. And that made us think a lot about the online world, because people do Facebook stuff all the time, and the tweets and all of this sort of stuff, but that's ephemeral and it moves off really quickly. There's something about a wiki page that's kind of solid and there and everyone can see it. And perhaps as academics we still get wounded by reviewers' comments, but we're used to putting ourselves up there and receiving flack. And these guys are just normal people who don't write, and so it didn't work, which was really interesting to us. But we salvaged it because we'd had 6 months of forum discussion. We had their email addresses, so we engaged them in conversation about what sort of stuff they would want on a wiki page, and we managed to identify key themes that were really important to them. And we didn't build a wiki page, but we built a suite of leaflets, one for health professionals, one for friends and family, and one for employers, using their perspectives, their words, and putting information out there that they wanted employers, doctors, healthcare professionals, and friends and family to know. So we salvaged something from it. Getting that published has been a real uphill struggle, because people that review it often review stuff that we do in labs and they don't understand the real world, and we were getting reviewers' comments saying, yeah, but you started out doing a wiki page and you've ended up with leaflets, you haven't met your objectives. And we were sort of saying, no, but this is real world, this is what happens. And we finally got it accepted a couple of weeks ago in Informatics for Health and Social Care, so hopefully that will come out soon and we can at least share the pain of trying to do real world research compared to stuff that you do in labs. So from the patient perspective, we had a clinical psychology student working with us down in the hospital, and she was really interested in the carer perspective, so we helped facilitate her doing a study with carers. Except I'm still talking about the patient, I see from my slides. So I'll just talk about this really quickly. Advice from patients for patients. Did a series of interviews, and my last question was, what advice would you give to someone who's just being diagnosed? That was just finishing up the interview, kind of let them say what they wanted to say, rounding it off really nicely. And it was so juicy and so interesting what they said that we were able to write a paper just from those last comments. Always think about the last question you ask in an interview, because you don't know where it might lead. And that was really interesting for us. So now we're on to the carer, which was Alison Lauder, who was our clinical psychology trainee. And she interviewed 10 carers of people who had CRPS. We angsted over what to call them, partners, carers. We just didn't know, because some of them were partners, some of them were lovers, some of them were best friends. So we ended up with the word carer, which we know has all sorts of other connotations, but that was the best fit that we could come up with. And we wanted to understand what their experience was of supporting someone with CRPS. And they were struggling to make sense of CRPS themselves. And quite often they were relying on the person with CRPS to explain it to them, because they didn't always accompany them to appointments, they didn't come in on the programme because we didn't have the facility to have a carer stream on our programme. So they were struggling to try and make sense of CRPS themselves. They knew it was about pain, they knew it was mysterious, and they were searching for a greater understanding and often becoming very frustrated with this. They seemed to be very in tune with their partner or friend, and they wanted to get across the message that they really tried to understand what that person's experience was like. And they had a shared vigilance. So the person with CRPS was very mindful about what was happening. If you walk along the street, if you're like me, most of the time I'm in a daydream. They can't be in a daydream because they're looking. People, when you start to look, people are quite erratic. And they're kind of looking to see which way someone's going to go. Are they going to come my way? Are they going to? So their carer will stand on this side and kind of act as a bodyguard, and they're also constantly looking. So it's knackering. It's absolutely exhausting for both of them. So there's this constant shared vigilance going on. attitudes towards rehab. They also wished for a cure, so there was a need for the broken one for them as well. And they didn't make sense of the rehab exercises. The rehab exercises we do can seem very strange to people outside. So I told you that, I always point to the arm because you guys can all see that. So my arm's got CRPS, super, super sensitive. I don't want to touch it, I don't even want to look at it. Most of the time I'm keeping it out of my vision of sight. We're trying to get them to look at their arm properly and to touch their arm. They might not even be able to tolerate clothes. Quite often they come and they're in the tiniest shorts in the middle of winter because they can't tolerate anything. Or they might wrap their leg in cling film because they can't tolerate trousers touching them. So we're trying to get them to desensitise. So the physios and the occupational therapists give them this bag of feathers and steel wool and silk and all sorts of different materials. And each person has a complete aversion to something different. And you work up to that, and you're looking at your arm and you're touching it with these different materials to try and desensitise it. You might encourage them to rub moisturiser in or all sorts of things. So imagine your partner coming home and pulling out a bit of steel wire and starting to rub your... If you've not been there and not been party to the explanation of what's happening, why it's happening, you're just going to think they are mad. And so these guys are really struggling to understand that. And they were also, out of the goodness of their hearts, scuppering rehab. So the person that couldn't tolerate trousers, for example, part of their rehab was to wear trousers and build up to wearing trousers for longer each day. Their partner was saying, well, if it hurts, wear a skirt. And so it's kind of, this really brought home to us the need to make sure that the partners and the carers were informed, because they were relying on the person with CRPS to explain stuff to them. So they were trying to support rehab, but they didn't have access to information. They struggled. They were reliant on their partner to tell them what was going on. They needed permission to take an active role from the person with CRPS, and they were constantly worried that they were stepping over the NAG list and really becoming nags. So they were kind of balancing this fine line and struggling with that. So that provided lots of food for thought for us as a team as to what we could possibly do to help carers without having them come in on the programme, because we didn't have funding for carers to come in on the programme. From the health professional perspective, I teamed up with Jeremy Gilbert, who's also down in Bath, and we were well aware that when you've got chronic pain and you have a flare and the pain is really intense, this might happen late at night or on a weekend, and our system isn't set up for people to be there for them. So they would go to A&E, and A&E is not set up for chronic illness or chronic conditions, they're set up for acute conditions. Research, mostly in the US, shows that people in A&E really struggle with these kinds of patients, and they have lots of derogatory terms for them. They call them frequent flyers or pain recidivists and things like that. And that then has an impact, because the person with chronic pain knows that that's how they're viewed, but they don't know where else to turn, so they rock up. They get bumped down the line because they're not going to die, but people who are going to die are coming in, so they can spend hours and hours waiting to be seen, and it's a horrible kind of trap. So we wanted to talk to some A&E experts and professionals and find out what their views and what their experiences were about people with chronic pain. So we ran a whole bunch of focus groups to do this, and it was quite fascinating for us to meet these guys, because they were so angst-ridden, which didn't come out in the literature that we'd read. They had been trained to fix people, and they can't fix people with chronic pain, and so they want to do stuff, and they can't. There's nothing they can do. Told you that medication doesn't really touch the pain. Our patients are quite often on a complicated cocktail of different kinds of drugs. The stuff that A&E people have access to probably isn't of the same standard that the people with CRPS are on, so the A&E people were telling us. They also don't want to put them on other drugs because they don't have the full history of the person in front of them. So they're really stuck knowing what to do. They don't have time to sit and chat, which is also what these people want. They just want to be heard, but they don't have time because there's someone dying here. They get upset, the patients get upset because the people are trained to come in and say, I'm trying to think of Quincy, cerebral hematoma, this, that and the other, blah, done in 2 sentences. It's taken them 5 to 10 minutes to explain to the ambulance man that's brought them in what's wrong with them, and then they hear the ambulance man giving 2 sentences description, so they feel that they've not been heard. So there's a whole catalogue of stuff going on. So there's system failures, there's a mismatch of what the individual wants and what the situation can give, and there's all sorts of clinical challenges going on. And it's a horrible mess. And the GP is the gatekeeper to all of this. And so we need to make much more clear to patients that GP is a gatekeeper rather than going to A&E. So we're still ploughing through some of that data at the moment to make sense of it, but we're trying to get 3 different perspectives of dealing with chronic pain. So what have we learned? The NHS really struggles to cope with chronic conditions. We knew that anyway, but we've got evidence now. There's a big drive towards self-management, but you can't have someone in just for a couple of weeks and then send them off and expect them to be able to self-manage. They need education, they need training, they need to have confidence that they can self-manage. They need to be able to come back and ask supplementary questions if something changes. There's a whole lot of stuff that goes on. So self-management is a big drive at the moment, but it's much more complicated than it seems at first. Support's inconsistent. There's a huge amount of misunderstanding. Some doctors don't believe CRPS exists. Some think it is just a psychological condition, and others are completely spot on, recognise it and refer very quickly. So there's a huge mix out there, so there's a need to kind of educate and raise awareness. We need to involve carers more. Big implications for the NHS, financial and practical, and for the family. If both of you are in on a programme, because it would be good to be in at the same time because you can see what's happening. Who looks after the kids? Who keeps the money coming in? So on and so forth. So there's lots of practicalities. Internet is useful. People turn to it. Of course we do. We all know Google, but it's double-edged. It's full of frightening stories, and you can read about stuff and become very afraid that's what's down the line for you, and that can impact on how you cope as well. Internet forums are useful. They're useful for us as healthcare professionals to lurk. We can think about the ethics and discuss that later, but to understand the issues that patients really talk about, one of the early message boards I got permission to lurk on, I was able to see people talking about their upcoming appointment with us down in Bath, and they were talking about how they were expecting to leave skipping at the end of the 2 weeks. So that really raised awareness that although we thought we were giving the message that there was no cure and that this wouldn't happen, we needed to do a bit more. So lurking as a health professional can be quite enlightening, but again, we need to think about the ethics of this. Asking patients what advice they would give to someone who's newly diagnosed was a really useful way for me, and an indirect way, of assessing how much they'd understood about what we'd told them. And mostly they'd got the message. There are a few bits that they hadn't quite taken on board, but that was a useful way of checking their understanding. We need to give carers permission to look after themselves. Their life stops as well, quite often, and their whole life becomes CRPS. We need to give them permission to keep on with their jobs, to keep on with their hobbies, to keep their life normal, and to not let their life shrink, and to encourage their partner's life to stay as full as possible as well. And carers can feel very guilty, and the person with CRPS can feel like they're a burden, and then you get stuck in this downward spiral. So there's something in there about needing to give the carers permission to look after themselves. We need to remind patients that their CRPS doesn't just impact on them, that it has an impact on other people. And we need to handle that carefully, because as I said, they're already thinking they're a burden. But they also need to remember that to look outside their bubble and be aware that it does impact on other people around them. Health professionals are really frustrated. Emergency department people can't fix this, so perhaps we need to raise awareness there. And Andreas Gogol has just added some A&E guidelines for people dealing with people that turn up with CRPS in the accident and emergency centre. So the guidelines are expanding to give some kind of protocol. So what questions are still answering? How can we do more with less? That's what everybody wants us to do. How can we harness the positive of what's already there rather than reinventing the wheel? Are we sharing properly? Are we using what we know, or are we constantly chasing that new exciting grant rather than looking at what's already with us and making the most of that? Are apps as good as we're told? There's all this drive to apps. Do we need to build in more human contact? I went to an interesting conference I think it was in Edinburgh a year or two ago, which was all about online support. And of course we had someone beaming in on Skype and the technology failed and something else happened and something failed and this, that and the other. And face to face, eye to eye, I don't know. I think we need more human contact. That's my personal perspective. More time, patients up front. If we can invest more time, give them the confidence, give them the self-esteem, then they're going to be more likely to self-manage, I think, if we can spend time up front with them. But these are questions that I want to explore. Can we study partners? They're really key. Can we study them? Why are patients still telling us some professionals don't believe in CRPS? What can we do there to raise awareness, get the message out? What aren't we doing yet that the message isn't getting out? How can we better publicise CRPS? What we need is a celebrity to get it. Maybe Simon Cowell or someone. I don't know. And what does adjustment really mean for someone living with CRPS? There's adjustment and acceptance and all of this. Do we really know what that means? We bandy these terms around, but do we actually ask them? I think those are really interesting. Do patients' outcome measures match those that we measure? So in other words, are we measuring the right things? For lots of the patients I work with, they wanted to be able to eat in public. They wanted to be able to wear high heels. That one patient wanted to be able to do a handstand because her 3-year-old was just learning to do handstands. We weren't allowed to help her with that because health and safety wouldn't allow us. But what is it that we're measuring? And we're often measuring things and not seeing any difference in the measures before and after the treatment. But we're seeing massive differences in the person's subjective well-being. So how can we encapsulate that and how can we measure that? Can we do more prospective studies? We need to work out what's adaptive, what's non-adaptive. Can we get some money? Can we follow people longitudinally? So that's my kind of nutshell. That's how I've tried to explore how people cope with CRPS. Thank you. Almost on time.
Questions, Karen?
From my various experiences with the health service, it seems to me that you could almost transpose a lot of this to quite a number of other conditions as well, for example, fatigue syndrome and other things. So this isn't, the problems you're seeing are not specific to chronic renal pain syndrome, which argues a wider, more systematic failure in the NHS to deal with these kinds of conditions. Particularly the issue of belief as well is a very difficult one, because I've had experience of people who do and don't believe in a particular condition. And some conditions there isn't the evidence to show whether there is a physical cause for the condition or not. There does seem to be some suggestion that CRPS may be similar or in some way related to things like arthritis, limb pain and amputees. That it might be some sort of central neurological pain rather than a peripheral condition.
And then Jenny Lewis is doing some really exciting stuff at the moment with some guys in Nottingham who had a magic machine. I haven't seen her do it yet, I'm dying to watch it. And they had it at an open day, and a lady with arthritis put her hand in it, and they were able to grow her hand. I think they grew it, and the pain went, her arthritis pain. And it's like, oh wow, and this was just this visual illusion. So Jenny's been playing with people with CRPS to see if it's a similar thing. And we do Candy McCabe started off this whole mirror therapy thing for people with CRPS, and that's like phantom mirror. So you're looking in the mirror, seeing your proper arm, while your other arm's behind the mirror, and there's all sorts of interesting things. And Helen Cohen, who I used to work with, used me as a normal subject, which pleased me immensely. And she managed to create pain in my arm by doing things. So it's clever what the brain can do. But yeah, I think what you said about there being an overlap and similarities across lots of different conditions, completely agree. And I think if we can find stuff that works in one condition and share it with the others, that's what we kind of want to do.
Do you think there's going to be any difficulty with the new model of provision in the health service? Are providers going to be sensitive to the needs of people with chronic renal pain syndrome, the budget holders? Or should I not ask that question?
I don't have an answer to that question. I don't know the answer. I think that we've got Andreas doing a fantastic job and his colleagues creating these guidelines that are the gold standard that how they should be treated. So I think we've got these and they're on the Royal College of Physicians website, so they're endorsed by them. So I think that's a really important first step, that these are gold standard things that are needed. How we get the longer treatment, because when you get thrown out, you're allowed 6 weeks hydrotherapy. These guys need it forever. And that's something that I don't know. I don't have an answer to that.
I'm just going to ask. I'm not asking a question.
Okay, we'll start there. Cool.
Sorry, I just wanted to ask, you know when we said that you did like the thing with the wire and the feathers and stuff, is that to help the patient to accept that it's a physical problem and create like a tolerance to the physical pain, or is it suggesting that there's a psychological element to it as well?
My understanding of what they're doing is they get touched and the pain goes off the scale. So, but if you touch them again, it goes up but less. So they're kind of increasing their tolerance to being touched. So it's more about the physical, but it's also about making them look at their arms. So the phrase that Richard Haig, you know Richard Haig? He's one of the consultant rheumatologists who trained, I think, in Bath and now works in Exeter, and he's always slightly naughty. And his catchphrase is move it, touch it, love it. And that's what it boils down to. So if your arm is hurt, you immobilise it. We're telling them it's moving your arm isn't going to hurt it anymore. So keep it moving, because if you stop using your arm, you create other problems. So move your arm, touch your arm to desensitise it, and love it. So make sure you look at it, because otherwise you're holding it out at these funny angles. So it's all about the physical.
Yeah, it was really following on from Martin's question. I find it's a really interesting talk, and I agree the guidelines hopefully will start to have some impact. But do you think then, and there are some features of a CRPS that are different to other painful conditions, but do you think that there should be maybe kind of distinct pathways for people with CRPS, or that there could be these more generic provision?
I don't know. I think we need to work out how we deal with chronic conditions. That would be a good start point, because we don't deal with them well at all as a health professional. So that to me would be a start point, and then if we could get an acknowledgement that there is a need for ongoing support, and actually if they had access to ongoing physiotherapy, they wouldn't be bouncing back into A&E or into other clinics because they'd be being cared for and looked after, and their self-esteem and their feeling that they would be able to self-manage would improve. So I think if we could do that as a start point, that would be brilliant. And then it might be that there might be specific pathways that are needed, but chronic health is just not well done.
No, I mean, from my experience, if you get, when a bunch of people with CRPS first meet one another, that's just as you say, it's like, well, I'm not the only one, because it's, never mind the GPs don't see very many, they don't see very many of themselves, do they?
No.
So that kind of shared experience is a big thing.
Yeah.
That's really a group.
When there's a we had some guys down in Bath, some of the patients that set up a CRPS at the Mid, and then it became CRPS UK. But with all these things, it relies on a couple of keen people, and then they get exhausted and they can't carry on, so it kind of falls by the by. And that's happened, well, the 7 years I was down in Bath, that happened twice, and it was really loved. It's the same as everything. People loved it, but they weren't willing to step up and take part in the organisation. Even though there was lots of positive payoffs from it. They ran a couple of patient conferences that we attended, and it was really positive, really helpful and useful. And it's gone because it relies on 2 or 3 key individuals that then exhaust themselves. So, yeah.
Can I ask a quick question? Sorry.
No, you go first.
I was just thinking the move it, touch it, love it thing made me think mindfulness. Is there a literature on mindfulness in relation to CRPS?
I don't know if there's literature on it, but I know that the guys that I used to work with are using it, and They also use acceptance and commitment therapy, which is big down Bath. And some patients love it, and some hate it. And again, part of that is teaching them that it's not a quick fix. Mindfulness is really hard. It's really, really hard, and you think it's just about breathing. It's really difficult, and not everyone's willing to invest in that time. And just sitting with your pain is really difficult. You know, all of you have shifted about in your seats quite a lot this afternoon. If you were being sort of properly mindful, you would breathe through it. That's really difficult. But there's a lot of work going on in the chronic pain field. In CRPS, I don't know. I'm bound to you.
No, not about to me, but I'm only in the same way that these individual practitioners may be using it, but I don't think there's a great mass evidence. There is a chronic.
Yeah.
I should have at the risk of being a terrible academic and asking about something not related to treatment at this point, which is already interesting. You, at the beginning, I mean, you talk about CRPS is, patients with this, respond very negatively to touch, and that's something I was aware of. I wasn't so aware of the symptoms of kind of other perceptual difficulties, and the examples used were all visual. Do patients with CRPS have kind of perceptual changes as far as auditory input, smell, taste, or
the ones that I've heard patients talk about have mostly been auditory. There was one that said her arm smelled different. Only one. But yes, I haven't heard others. Mostly it's visual, looking at the arm, the leg, and how they actually see it, or don't see it. It's here, then there's a gap, nothing, and then there's this big hand.
But is it isolated to the visual perception of the limb rather than necessarily perceptual changes about the wider world?
Well, it's both. It's the limb, but also, as I said, sometimes they see the buildings kind of shimmer, and they talk about strange, seeing things walk across the room. Things like, not many of them, but some. Mostly it's about here, and it's about seeing the limb as being much, much bigger, which is why they need a bigger personal space, because they think someone's going to bump them much sooner than they will. And there are some evil patients that are lovely because they help each other. So they blew up surgical gloves, and they would wait till someone wasn't looking, and then they'd throw it like a balloon at them, or they would hide the bit of material that their fellow patient hated the most in bed when they weren't looking, and they would do all these kind of little fun games that they play with each other to try and help each other with the desensitisation. And when we caught on that was happening, we made sure that they consented each other, because otherwise it's bullying and harassment. But those kinds of things could be really good, and then they can take that home and they can play balloon catch with their children, which is also about desensitising themselves, and the balloon's not going to injure them, so they can work out ways of incorporating stuff into their everyday life that isn't quite so strange as stroking yourself with some Brillo pads.
Do those visual changes differ with pain levels as well? So, for example, does that hand get bigger when the pain is greater?
Yes, I think it does. In most of the guys that I worked with, What I should have done as a picture, at the end of Jenny's piece of research with some people, one of the guys was a really good cake maker, and he made a cake of his forearm, an exact replica of his forearm, and the inside was red sponge, and the outside, and he painted it, and the nails were like real nails and everything, and he presented her with this at the end of taking part in the research. And that must have been really difficult for him to do with all this perceptual stuff going on. That was an amazing gift. And then she really enjoyed giving everyone the finger at the end. That's Jenny. I've got a picture of the finger on my website.
But the hair thing, when you said that one arm's hair is real, that's real, that's not just something they can see.
No, that's real. And again, it doesn't, these symptoms I've taught, not everyone gets all of them. So some people will get them and others won't. Some people get, their arm is much more sweaty. But I have seen, very, very thick dark hair. and not on this other. It's strange, it fascinates me. And there's a lot to learn, I think, still.
The advantage of having a holistic approach to your patients is that you learn quite a lot about their lives before. Do you then get any insight into particular characteristics that might predispose people to suffering?
We look at, I get them to draw a grid of what their life looked like before CRPS, and everything has an individual box, so children, hobbies, all of these things, and the grids are often enormous. And then I get them to draw a grid of what their life's like now, and often it's pain, and maybe husband or wife or child, and that's it. And making them draw that makes them see the contrast that's happened incrementally, bit by bit. Suddenly it's really stuck, and then they can start thinking about how to build up their life again. And we look at how they coped in the past, because we also look at, they blame everything on CRPS. I can't plan my life anymore. I can't do this, I can't do that. And I would say to them, how often before you had CRPS did you plan your life when something happened? I set off to travel here today, and the line between Crewe and Liverpool is broken, so I was then set on an interesting adventure to get here in time. So we look at what they did in the past. We also get them to distinguish between what CRPS induced and what isn't, and look at how they coped and whether their coping strategies are appropriate. So for many people, they engaged in sport, and if you can't be as mobile as you were before, and that was your stress release, we look at other ways of doing that. So some people have taken up archery, others have taken up different kinds of sport, some have taken up tandem cycling. But that takes quite a big shift to be able to let go of, I was a really good rugby player, to I'm going to learn to be an archer and I'm not very good at it. So there's so we look at what their strategies were for coping, and whether we can build in adaptive versions that will work for them in the same way. Does that answer your question?
Are there any characteristics that would appear to make somebody more likely to suffer from? I mean, you say you don't actually know, nobody knows what the actual cause is, but do you detect any particular characteristics about individuals that mean they're likely to suffer the condition in comparison to somebody else who might go through, for example, the same injury, not deep on that?
No, I think the research is inconclusive that's been done on that. So no, and in a way that's good for them, because otherwise that feeds into that being their fault in some way. But no, I'm not aware of anything. But I think people have looked, and it's been very inconclusive.
As a corollary to that question, has anyone looked at heritability or genetic possibilities for this, or genetic links?
I'm sure people have. I don't know that research.
Anyone else? No? In that case, thank you very much, Karen.